Thank you all for joining today's Pediatric Clinical Pharmacology Lecture Series. It gives me great pleasure to introduce our speaker for today, Dr. Diane Mould. Dr. Mould obtained her bachelor's degree at Stevens Institute of Technology in 1984 in chemistry and chemical biology. She received her Ph.D. in pharmaceutics and pharmaceutical chemistry at The Ohio State University in 1989. She spent 30 years as a pharmacokineticist, in industry, where she specialized in population pharmacokinetic and pharmacodynamic modeling. She was an associate research professor at Georgetown University. Dr. Mould is involved in clinical trial simulation and optimal study design in drug development. She was a member of the scientific advisory group for Farsight, where she assisted in development of clinical trial simulation software. Now, currently, Dr. Mould is president of Projections Research Incorporated, a consulting company offering pharmacokinetic and pharmacometric services. She is also the founder of Bayesian LLC, a company that develops systems and individualize doses of drugs that are difficult to manage. She has published 104 peer-reviewed articles, 19 book chapters, made 129 national and international presentations, and presented 6 podium sessions on advanced modeling and simulation approaches. She's an adjunct professor at the University of Rhode Island, OSU, and the University of Florida, and teaches an annual class on disease progression modeling at the National Institute of Health. She is a member of the editorial board for Journal of Pharmacokinetics and Pharmacodynamics, Clinical Pharmacology and Therapeutics, and is on the scientific advisory board for Clinical Pharmacology and Therapeutics, Pharmacometrics, and Systems Pharmacology. She is a fellow of the American College of Clinical Pharmacology and of the American Association of Pharmaceutical Sciences. Please join me in welcoming Dr. Mould.
Thank you very much. So I have kind of a long presentation, so I'll just get right to it. Get this thing to move. Sorry. Again, just to let you know, again, I am the president of a consulting company, and I do a lot of work with dashboards, just to let you know that dashboards often recommend doses or dose intervals that are not consistent with the labeled dose. So some of the issues that you need to consider when you're working with or extending into pediatrics is that some diseases are inherently different between adults and pediatrics. For example, some cancers occur predominantly in pediatrics and others predominantly in adults. Pediatric cancers are often different than adult. Unlike many adult cancers, childhood cancers are generally not strongly related to lifestyle or environmental risk factors. Pediatric and adult patients can also react differently to treatments. Pediatric cancers tend to respond better to chemotherapy, and children do tend to tolerate chemotherapy, for example, better than adults do. However, cancer chemotherapy and radiation can have long-term side effects, so pediatric cancer survivors do need careful attention for the rest of their lives. So talking a little bit about disease progression, these often require a lot of data to develop. The metrics of disease progression are variable, especially if you have subjective assessments. So, for example, we've done disease progression modeling for depression, and it's what I call a soft endpoint, because every person can look at the same patient and come up with a different Hamilton depression score. So it does tend to make things more variable. In those settings, you tend to need more data from more subjects in order to get a good idea of what the actual progression looks like. You also need data collected over a sufficient period of time to develop a function that adequately forecasts the progression of the disease. And the bigger problem is these days we don't usually have what they call a natural history in untreated patients. Most patients get treatment very early in their disease, especially in developed countries. The other thing that you need to remember if you're developing these models is that the standard of care changes over time. So the expected progression in an active control arm needs to be updated periodically. The plot below, I'm looking at an example of a disease progression status. And if you look at the bottom axis, the x-axis, you can see that goes over time. But what's important to know is that these will be, for example, weeks. You need to have data over a sufficient period of time in order to assess the progression rate, even with a simple linear progression function. So it's got to be at least 1.5 to 2 half-lives of progression. So there's ways to address some of these issues. You can pool data from multiple previous studies to build models. A lot of times, if you work with major academic centers, they may have long-term data. You can utilize published summary data to do, for example, a meta-analysis, but then you need to ensure that the summary metrics, so mean response versus median response versus a geo-mean, you need to make sure that they can be combined in order to evaluate these as part of a meta database. The other thing that I've often used is finding published models and use them as what we call an informative prior in Bayesian system. And then finally, collecting bedside data to refine models, but you need to verify the quality of the data. Some of the bedside data is not documented as well as we would prefer. And bedside data can often be combined with meta-analyses. So basically, if we're looking at disease activity versus disease severity, activity looks at a cross-sectional assessment of biological impact on symptom signs and endoscopic biomarkers, whereas severity is a longitudinal or disease course and historical factors that provide a more complete picture of the prognosis and overall disease burden. The problem is that, for example, with IBD, activity is pretty much all we have available, and these don't necessarily directly relate to progressive damage. And I'll show that here, where we're looking at the time course of progressive bowel damage from inflammatory activity. So the blue lines are inflammatory activities, for example, CDAI, which is the Crohn's disease activity index, or C-reactive protein. And on the orange line, we're looking at the actual outcomes of some of these things. So what you can see is in the blue line, you're seeing these little peaks, which indicate a flare occurring. And typically, when you see a flare, you're going to see an increase in the digestive damage in the patient. So having multiple flares may lead to stricturing, and then continuing that, fistulas and abscess. The patient may have to undergo surgery, but if you don't stop these flares from occurring, the process will just start all over again with strictures, etc. So the idea is that if you can stop the flares, you may be able to reduce the progression of the disease. So let's talk about pediatric IBD, which is where I do an awful lot of my work. And the incidence of pediatric IBD is really increasing a lot. These present in childhood and adolescence and form about 20% of all newly diagnosed cases of IBD in the United States. The age that we're seeing these patients is actually getting lower and lower. It used to be very rare to see a patient less than 6 years old with IBD, but now they're calling it very early onset IBD. And even as young as 2 years old, we're seeing some patients with this. It's not anywhere near as common as the older children, but still is being seen. Unlike adults, growth failure is an important sign of pediatric IBD, and it's seen most commonly in Crohn's disease patients. Childhood onset IBD is characterized by extensive intestinal involvement and rapid early progression. So it's important to get these patients under control as quickly as possible. So a lot of drugs that are used to treat IBD are monoclonals or MAbs. MAbs have very complex pharmacokinetics, and we'll see that in a couple of minutes, but there are a lot of factors that impact MAb PK. We have a high interpatient variability, and the more important thing is that unlike chemicals, the pharmacodynamics can affect the pharmacokinetics. So in other words, if the patient is getting worse, their clearance will get faster. If the patient is getting better, their clearance will slow down. We also typically see a high treatment failure rate in adults. And if we look at this plot over to the right, we see that during induction, which is this area, we lose 20 to 30% of the patients during induction, and these are referred to as primary non-responders. And then when we see during the maintenance, we lose about 10 to 20% of patients per year. So those are called secondary non-responders. And so you can start with 100 patients and you can see how quickly you'll run out of patients in that cohort. So basically, the problem is that most of the labeling for pediatric monoclonals has much lower exposure in pediatrics than adults. So if you look over here, these are the adults. These are our 6 to 17-year-old. They're about 25% lower. And if they're in the 2 to 6, they're about 40% lower than adults. And for patients with more aggressive and extensive disease, that's kind of upside down to where it should be. So we consequently see a higher failure rate in pediatrics than we do in adults. So I was talking about how complex the pharmacokinetics of monoclonals are, and that's kind of highlighted in this diagram here. We have multiple routes, including what we call antibody salvage. So the FcRn, or if you're old enough, like me, Bramble receptors that recycle IgGs and return the naked IgG back into circulation so it can continue working. You can have metabolism, which is breakdown by proteolysis. You can have target-mediated binding, and this is a little bit more consistent with, for example, drugs in oncology, monoclonals in oncology. You can also have TNF receptors binding to Fc gamma receptors that can regulate clearance through the reticular endothelial system. And basically, remember that binding usually with monoclonals relate to clearance, not the volume of distribution. It's kind of backwards to chemicals. You can have cellular uptake. Again, this is a little bit more common with oncology monoclonals. And then you have anti-drug antibodies, and I'll show a diagram, but there's a lot of factors that contribute to how immunogenic a monoclonal will be. And then the last one, which is really more important in things like IBD, you can have disorders of endogenous catabolic pathway or excessive loss through the urinary or GI tract. So, for example, in IBD patients, they found, and there are a couple of studies and they're published, you can see down here, Capel et al. And Beacon et al., where they were looking at IgG in the gut in patients that had IBD versus patients who did not, and they saw increased intestinal clearance of IgG that was related to the lesion severity. So the more severe the disease, the more likely it is you're going to be losing drug through the intestinal mucosa, and it does not go back into recirculation. So there's a lot of differences that I mentioned. I think the one that's the most important is that the PK of biologics is often dependent on the pharmacodynamics. You have a variety of other things like nonlinear pharmacokinetics that may occur, and that's again more common in oncology monoclonals. The breakdown is not metabolic, it's usually proteolytic. Renal clearance is uncommon for high molecular weight, so monoclonals generally are not cleared renally, with the exception of some severe renal damage like FSGS patients. And binding implies clearance, not volume of distribution. And these drugs typically have what they call poor tissue penetration. They do get into the extracellular fluid, but they do not get into the cells unless they're taken in through endocytosis. So here's an example of a drug called daratumumab that's used to treat multiple myeloma. And multiple myeloma patients excrete M proteins, which can be one of two types. One is an IgG type M protein, and the other is the IgG-A type protein. And typically the M proteins that are IgG fall into this category of non-responders because the IgG type M protein saturates FcRn, so daratumumab is cleared more quickly. It doesn't get recycled. Whereas if you go to the IgA type, they're in the higher part here. They basically have better response because they don't have that competition going on. Then off to the right here, this is some work that was done by Waldman and colleagues. And he was looking at the IgG survival time. And so, for example, patients with low IgGs, their half-life is quite long. Patients with high IgGs, their half-life becomes quite short. So proteolytic breakdown is really usually the prevalent route of clearance for monoclonals. It is usually weight dependent. So patients who are heavier have faster clearance, but it's not a linear thing. So an 80-kilogram patient will not clear the drug twice as fast as a 40-kilogram. So weight-based dosing does not fix things. In fact, it's usually a very bad dosing metric. Um, so if we're looking, for example, here, drug B, where you have a wide range of weights and the patients have very similar PK, if you use weight-based dosing, you've just made things much worse. And this is kind of an unusual situation where we have fairly linear clearance based on weight. And here, a weight-based dosing would help. But drug A type drugs almost never occur. So if we were looking and expecting linear clearance with weight, we would expect something along the blue line. But what we typically see is something along this red line, which means that when you use weight-based dosing, the heavier the patient, the more drug exposure they get. The smaller and lighter the patient, the less drug exposure they get. There's another aspect that we need to consider, particularly in the United States, since obesity is on the rise. Obesity is similar to a low-grade systemic inflammation. And we have to consider that adipose tissue is effectively an endocrine organ that synthesizes a variety of peptide and non-peptide compounds, including TNF and IL-6, which are basically inflammatory cytokines. Um, so basically, higher circulating TNF means a higher antigen burden. And because the patients are obese, typically their bioavailability is compromised when they are given monoclonals subcutaneously. So the increased inflammatory cytokines in patients and the poorer systemic absorption generally means that they will more likely to develop anti-drug antibodies or ADA and often need either higher doses or doses given more often. This is some work that was done for CAMPATH, which is a monoclonal antibody for cancer. And what you can see here is the brown dots are white cell counts. The blue dots are the CAMPATH concentrations, and they're getting the same dose. But it isn't until the white cell count is decreased that you begin to see measurable concentrations of CAMPATH, and then they just continue with the same dose, although this patient did get a short drug holiday. And so you're giving them drug where there's really no target left. So when you're treating patients with a drug like this, you really should be paying attention to how much accumulation you're getting because you may be giving drug when the patient doesn't need that much drug. You also have competitive binding when you have both cell membrane-bound receptors and soluble receptors. So typically the ligand for the receptor binds preferentially to membrane-bound receptors, but monoclonals typically bind more preferentially to soluble receptors. And so in many cases, we use an induction dosing in order to try to saturate and remove the free soluble receptors so that the monoclonal has a chance to get to the membrane-bound receptors. So we have to consider clearance as one of the more important PK parameters when we're dealing with this. But what we can see right away, looking at this chart of clearance versus dose versus disease, for the RA and ankylosing spondylitis patients, their clearance is quite a bit slower than for IBD patients. And some questions were, is this caused by the disease or other factors like assay variability or other concomitant medications? And as it turns out, it's really more related to the disease and the disease severity. And in particular, it's usually due to very low albumin in the IBD patients. So albumin doesn't cause changes in monoclonal clearance, but it is predictive. It undergoes the same recycling through FcRn that monoclonals do. But also, if you have, for example, protein-losing enteropathy, albumin will be lost as well. And so typically what we see is patients with low albumin, it's associated with worse diseases. And I'm looking at simulations here for infliximab, for vedolizumab, for adalimumab, and ustekinumab. You can see that the patients with low albumin, which are the ones with the red lines, have substantially lower concentrations, in particular trough concentrations, than you have for patients with higher albumin. meaning that these are patients that you may need to dose more frequently or at higher doses. The other thing question was, is this atypical clearance or protein losing enteropathy a real thing? And this is some work that was done by Hanke Branse at Academic Medical Center in Netherlands. And they wanted to see whether or not they could determine whether monoclonals are lost through ulcerated mucosa. And so basically, they dealt with patients that had severe IBD. They were dosed with an initial dose of 5 milligrams per kilogram, and they took serial fecal samples over the first 14 days following that first infusion. And they found that they could detect infliximab in feces of these patients, with the peak fecal infliximab occurring the first few days after infusion. Non-responders to induction had lower serum infliximab concentrations compared with responders, but they also found that non-responders had statistically significantly higher fecal infliximab concentrations, supporting the theory that patients that have severe IBD are losing their drug through protein losing enteropathy. And again, this may need to be compensated by more frequent dosing in these patients. Other things that we see is depends on other diseases the patients may have. So, for example, if you're looking at diabetic patients tend to glycate proteins. And you can see that distribution of glycated proteins in normal versus diabetics is substantially higher. But the other thing is that glycated proteins clear more quickly. And so if a monoclonal is glycated, the clearance will be much quicker as a consequence. So patients that have, for example, psoriasis, RA, or IBD, and diabetes, you need to pay much more careful attention to how much drug is in circulation for these patients. So if you look, for example, at patients that have even chronic periodontal disease, the clearance of these monoclonals can be increased by about 20% due to diabetes, also for other inflammatory diseases that they may have. So getting a background on the patient is very important in order to treat them appropriately. I got to work on this keyboard. Sorry. So I mentioned that the situation with anti-drug antibodies is rather complex. So it's a variety of things. For example, the sequence variation, in other words, the more human the monoclonal is, generally the less immunogenic it is. Also, the glycation of the protein can have something to do with it. So the type of glycoproteins that are created when they're manufacturing this can have something to do with anti-drug antibodies. But there are other factors like contaminants and impurities, the formulation, the route of administration. So, for example, IV is usually the least immunogenic, with the sub-Q being more immunogenic. But that's not always the case. Every time you work with a monoclonal, you have to always keep an open mind. There was one drug I worked with that was targeting the white blood cells, and sub-Q administration is generally taken up through the lymphatic system. So when we administered the drug subcutaneously, we were giving the drug to what we would call a target-rich environment. So we got better efficacy and less immunogenicity in the sub-Q route. So these are just rules of thumb you have to keep in mind. The dose is also another thing. In other words, patients that have very low dose or very low exposure tend to become more immunogenic. They develop anti-drug antibodies more quickly. The other thing that we worry about is what's called episodic exposure. So in other words, if you saw with the profiles for the different albumin levels, patients with low albumin go for long periods of time with no circulating drug, and that can actually bring on anti-drug antibodies. So you want to prevent that as much as possible. The other thing that we're seeing, of course, is that assay technologies for ADA have improved dramatically. So the anti-drug antibody propensity that you see in some of the older monoclonal labels are a bit out of date. And so it's actually generally a higher percentage of patients that are often in the older labels. And then there can be other things like patient characteristics, for example, diabetes. And then there are always unknown factors that can contribute to this. We also learned that maintaining measurable concentrations is really important. So, for example, when we look at albumin, as you might expect, patients with low albumin tend to have more earlier and more dramatic withdrawal of the drug. Here we're looking at the line of therapy. So if a patient was on a previous monoclonal, it's not the same. If they had developed anti-drug antibodies, those should not be cross-reactive. But whatever it was that made them develop anti-drug antibodies to the first monoclonal is still going to be present when you give them a second monoclonal. So they're going to be more likely to develop them when they go to a second or third line. And then when we look at other things like the patient weight, again, you can see patients with low weight tend to have more anti-drug antibodies. And then when we look at the actual, whether their trough was lower than, for example, 3, now this was interesting because we saw what's called hormesis. You can see that the lowest group, which is the black line, is not the lowest one in this plot. And we did a little sleuthing and found out that the physicians were actually quite conscientious in this evaluation and had corrected the patients with the low troughs to give them higher doses and get them higher concentrations. So you have to check, especially when you're getting clinical data. So we came up with a model looking at the probability that the patient was not going to develop anti-drug antibodies if their troughs were less than 3. And you can see how quickly that falls off. But if you could keep the patient's trough concentration at higher than 3, the probability of the patients developing anti-drug antibodies would be much reduced. Also, we found that early and appropriate reaction can sometimes reverse patients that develop anti-drug antibodies. One of the studies that we did with Dr. Marla Davinsky using a software package allowed her to aggressively intercept patients that were developing anti-drug antibodies, and many of those patients reversed back to being the negative anti-drug antibodies. But what you'll see in the patients that are not being treated, the dashed line are the anti-drug antibody titers, is that the concentrations start falling. You have longer and longer periods with no measurable drug, and the titers just get higher and higher. Whereas once the patient in the green line is detected as developing anti-drug antibody, they go to more frequent dosing. They keep the trough concentration up a little bit higher, and the patient's anti-drug antibodies are no longer detectable. So you've got a whole lot of things to consider when you're using monoclonals. And again, this is true even of patients that are getting oncology monoclonals, but the anti-drug antibody, the body size, the disease and the severity, the use of other immunomodulators, which are sometimes used like methotrexate, azathioprine. Serum albumin, if it's low, that's going to mean the patient's going to have faster clearance. It's true in inflammatory diseases and also in cancer. Patients that have high circulating inflammatory cytokines, and then, of course, that atypical clearance, for example, the protein-losing enteropathy that I mentioned previously. So if we look at a clinical scenario, if we're treating a patient with severe UC, we administer 5 milligram per kilogram at 0, 2, and 6 weeks. Initially, we see improvement. CRP initially appears to decrease, but then we see a loss of response, the symptoms return, and the CRP begins to increase again. So the question is, what happened? And you can see here that what's happening is you're getting very long stretches of time in this patient where drug level is extremely low. So the question is, do you increase the dose or shorten the interval? And here I'm showing a simulated picture, so this is not from a real patient, where we look at a dose that's been increased threefold, 5, 10, and 15 mg per kg. But if we do a log transform, it's a little bit easier to see what the benefit was. And what you're getting is actually a very short improvement in the amount of time that the drug is at or above a target concentration. So shortening the dosing interval is usually a better option. So here's the example of our patient, and the question is, what do we do? The first one we can look at is patients going to a higher dose. You can see that doesn't do much. If we look at playing around with the dose and dose interval, we don't want to spend too much time doing that. And what you really want to do is look at the dosing interval. And that's really the best thing. It's not just the dose, it's the dose interval that plays a big role in how successful the treatment with monoclonals are. So there are a number of strategies to maintain effective exposure. Here I'm looking at a simulated data for infliximab, and you can see we're trying to stay above 1. And even in some patients with 20 days, they're already below that target. If we do a weight-based change, it does help a little bit. If we take into account weight and albumin, it's a little bit more improvement. And weight, albumin, and ADA does even slightly better, but these are just 5 mg per kg. If we look at the green, that's PK guided. So when the patient's trough starts looking like it's going to get low, you actually shorten the dosing interval. So basically, the PK guided dosing reduces the number of patients that fall below your target from about 30% down to about 4%. So why is it so much better to do this? If you look at the label for the pharmaceutical monoclonals, sometimes weight is in there. So, for example, infliximab has weight-based dosing. Sometimes there's a little bit of information about reducing the likelihood of anti-drug antibodies by co-administration with immunosuppressants. But dashboards include all of this information: weight, albumin, anti-drug antibody, glucose, CRP, sex, and use of immunomodulators. So by accounting for all these patient factors, patient exposure can be controlled much better. So this is a picture of my race car back in my crazy days. And you can see in the back here, I've got a little computer behind my steering wheel. And in the car, it provides information on my speed, the gas, oil pressure, but it also includes a GPS that can forecast my lap speed and other performance issues and give me a critique for pretty much every turn I take. And basically, this is similar in many ways to dashboards in clinical practice because it utilizes bedside real-time data. It makes use of a population PK model, is what we call a Bayesian prior, and it tracks response to treatment and other prognostic factors, forecasts exposure, and helps determine appropriate doses. So how does it work? And so basically, for example, it's pretty simple. You just enter the patient information, update the information with, for example, weight, CRP, albumin, etc. And then you pick your target trough. Here we just picked 3. And it's going to tell you when that patient is going to cross the target line, so you know when the dose should be. And it'll give you a variety of different dosing options that you can decide. For example, if I want to go to 8 weeks for this patient, I'm going to need to use 4.2 vials of drug. But if I want to go to a 5-week exposure, it's going to be about 1.5. So it can help you manage not only the patient's disease, but also the expense of treating that patient, which may be useful to the patient. So this is an example from a clinical consult in a patient. This patient was getting about 5 mg per kg every 8 weeks, but if you look at their CRP, it's quite high at 150, and the albumin is quite low at 3.2. So we ran a forecast for them, and the software basically said you're going to have to shorten the interval to 4 weeks. So the physician then has a question: should I shorten the interval or increase the dose? And this is the important thing about dashboards. The final decision is always up to the treating physician. So what the physician decided to do was increase the dose to 350 mg because he didn't want to give it every 4 weeks. So the patient came back later, and you can see he's got this higher dose. CRP and albumin are unchanged. And what we're seeing is that their trough concentration was even lower. And the dashboard was still saying, gotta give it every 4 weeks. So the physician said, okay, I'm going to try the every 4 weeks and see how that goes. And so they kept it at 7.3 mg. And you can see that CRP is reduced, albumin is beginning to improve, and the trough concentration is much better now. So he was able to reduce that back down, and you can see CRP has reduced even further. Albumin has gotten higher. And what we're seeing in this patient is that the clearance, which is the solid red line here, is decreasing over time, which, as I mentioned, if the patient is responding to therapy, this is exactly what you would expect to see. So clearance is a good prognostic indicator for these drugs. So what we're learning is that monoclonal clearance is often a good indicator of impending flares and loss of response. So for example, here's a clearance diagram from a patient whose clearance was progressively getting higher and higher. And then they had a flare and a loss of response in anti-drug antibodies. So the patient had to discontinue drug. The other thing that dashboards can do is that all relevant data can be brought together in order to update models and get better information on patients that are more recent with, for example, better assays. So basically, the first test of dashboard dosing was conducted at Academic Medical Center. It was adult IBD patients in maintenance. We had 40 patients on clinical guided or CG dosing, 40 patients on precision guided dosing. And the results were, after a year, you can see the black line here is the clinical guided dosing. And the red line up here is the precision guided dosing. We had a highly statistically significant improvement in drug survival. There were just a few things. We did have some patients that had a reopening of old fistula that was not considered to be a drug failure, but we did have several that were lost to response. When we looked at the clinical remission in FCP, you can see that was also statistically significant. And then also just fecal protectin levels were also better at 12 months for the patients on the precision guided dosing than they were on the clinical guided dosing. So we took data from the Celltrion study. This was the phase 3 study that was comparing the biosimilar Celltrion with the originator in patients with active Crohn's disease. And we used that to determine initial clearance and correlate them with clinical outcomes at 12 months. And what we saw was pretty much what you would expect. The initial clearance for patients with very high clearance, you can see the falling off of these patients with time is pretty dramatic, where the patients with the slower clearance stayed on drug much longer. We also saw that there was a benefit for immunomodulators, where the patients who were getting some immunomodulators tended to stay on better. And then also drug withdrawal, the same thing. Patients with faster clearance tended to be withdrawn more, earlier than patients that were not. And that would make sense because it's unlikely that they're responding well. So we saw that patient age, sex, and disease duration was not influential here, but the initial clearance and the use of immunosuppressants are very predictive of early anti-drug antibody. So these are the probability curves. This is the patients with mucosal healing. And again, patients with low clearance have a much better probability of having mucosal healing. Patients, for example, with anti-drug antibodies, you can see a very steep probability curve for patients with high clearance having a very high likelihood of developing it. So curves like this serve as actually kind of an indicator. They're obviously probability, not definite. So a patient with a high initial clearance would be one that you'd probably want to spend a little bit more time following up with. And the same is true of all the others. This is a combined diagnostic where we were looking at fecal calprotectin, CRP, and mucosal healing. So the probability of having all of that was a little bit lower. We see this in other patient populations as well. So, for example, we were looking at probability of patients developing anti-drug antibodies with basically patient weight. And as you can see, again, as the clearance increases, the probability of anti-drug antibody increases. And similarly, patients that have a higher weight had a higher probability as well. It's not limited to inflammatory disease. This is some work that was done by Turner on pembrolizumab. And what we're looking at is the first quartile of clearance for 2 mg per kg and the first quartile of 10 mg per kg. And then here's the lower fourth quartile. And you can see that the drug survival, actually the survival of the patients, It really didn't matter whether they were getting 2 milligrams per kilogram or 10 milligrams per kilogram. Patients with higher clearance, which is the ones down here, are not doing as well with the drug. And you can see it really, again, just doesn't seem to matter whether they're getting 2 mg per kg or 10 mg per kg. So low initial clearance is associated with better overall survival, regardless of the dose with Pembro, and probably true for other monoclonals as well used for cancer. We ran a small proof of concept study in 10 patients. These were patients with acute severe disease, and usually you get colectomy in 20 to 40%. This is a very small study. It only had 10 patients. And basically, what you're seeing with acute severe is what they call accelerated inductions, more frequent dosing in the first 2 weeks, has been reported to reduce colectomy rate. What we had here is 8 of 10 patients treated using the dashboard, all completed induction. There were 2 patients that had developed anti-drug antibodies. One was previously treated with infliximab and didn't actually tell the treating physicians until they actually developed anti-drug antibodies a second time. So that one we're not so sure was terribly useful. But what we did is we looked at the clearance over time in these patients, and you can see that in those patients where clearance declined, the probability of anti-drug antibodies declined, which is the red line, and the probability of good things like mucosal healing and CRP normalization actually improved. And for patients whose clearance went up over time, you can see anti-drug antibody clearance, anti-drug antibody probability goes up as the other good indicators go down. So it's not just baseline clearance, it's the clearance over time that these patients have. And if you can get their clearance to slow down, then basically usually you can improve their outcomes and how long they can stay on drug. So this was a study in adult and pediatric IBD. It was a one-arm open label study looking at the effectiveness of individualized dashboard-based dosing. There were some adult patients. I think it was about 20% of the patients in the study were adults. The rest were all pediatrics. And the first dose was at the treating physician's discretion, after which the dashboard iDose was used. And what we were looking at was a couple things. One is, are these patients getting higher exposures with the dashboard than they would be getting the labeled dose? Now, the initial dosing was physician selected. So some of them went to 10 mg per kg right away, which is not in the label either. But then we did a simulation for 10 mg per kg and 5 mg per kg and looked at the Cmax. And you can see that although the patients on iDose tended to have somewhat higher Cmaxes, it wasn't altogether that much higher than the label dose. The C average gives us, again, a slightly higher exposure with the 5 and 10 mg per kg, which are the green and the blue, being quite a bit lower. And what we're seeing in particular is that the C-min is much higher for the iDose treated patients than it is for patients just getting the labeled dose. So 5 mg per kg every 8 weeks or 10 mg per kg every 8 weeks really doesn't seem to matter. You seem to be at very low concentrations very quickly. So this is the drug survival. And what they were looking at was compliance with the software. And what they found is that the patients who were on time for both actually tended to have no dropouts during induction. If you remember, normally that's 20 to 30%. And here it was none if they were compliant. We did have patients that were late for both infusion 3, which is the last induction, and infusion 4, which is the first maintenance dose. We also had ones that were late for 3, but on time for 4, and then on time for 3, but late for 4. And you can see that no matter what they did, if they did not follow the projected dosing regimen, they had a much higher tendency to fail therapy. And so basically, the other thing is we had quite a few patients that were still on follow-up less than 1 year. That's why there's so many X's here. But being compliant is actually very important as well, which I'm sure everybody understands. And we saw the same thing with Anti-drug antibody formations, again, the patients that were compliant had virtually no anti-drug antibody formation until quite late in the study, whereas the ones that were late for dosing tended to have much higher and much earlier anti-drug antibody formation as well. So what I wanted to talk about a little bit is that we have an issue with approval of these monoclonal antibodies in pediatric. At present, only infliximab and adalimumab are approved for pediatric use in IBD, and this compromises the ability to conduct adequate, well-controlled studies in pediatric patients because in many cases, patients tend to go and get infliximab and then fail it. They go to adalimumab and then they fail it, and then they can't enroll in any of these studies. And it's not like these drugs haven't been in use for quite a long period of time. Certolizumab, for example, was approved in 2008. Vedolizumab was approved in 2014. Ustekinumab in 2016. And golimumab was approved in 2013. So we've had more than 10 years in most cases of experience with these drugs in adults. And in fact, many publications of off-label dosing have been done. So the idea is that pediatric extrapolation may be a possibility, which unfortunately hasn't been utilized here. But the idea of you can use the adult trial data for children with full extrapolation, meaning that you allow the safety and efficacy to come from adult clinical trials and only look at PK and any safety in pediatrics. And it's supported by the fact that it's a similar disease in adults and pediatrics, and the drug action and PK levels are the same. So this would reduce the need for pediatric efficacy study and would theoretically promote access to safe meds in children, although unfortunately, as you can see, this has not been the case. So there was a 2025 article that reviewed 14 papers for the evaluation and effectiveness of, for example, vedolizumab. And what they found is that 36% of all patients got clinical remission at 6 weeks, 50% at 14, and 48 and 53% at 22 weeks. So these patients are actually doing the same or slightly better than adults. 45% of patients maintain clinical remission after a year. Less than 8% of these patients had serious side effects, and 15 to 34% experienced mucosal healing. So vedolizumab has been demonstrated in multiple studies as being safe and efficacious and similar efficacy to adults. This is some work that we did with Dan Turner, and this was data from 129. It was called the VedoKid study. And we took the PK data and evaluated using a published model as a Bayesian prior. And the PK model was then used for exposure response evaluation, investigating doses in pediatric patients. So at week 30, 81% of children remained on vedolizumab. 39 of the exposure response evaluations were in deep biochemical remission. And we saw increased baseline clearance was associated with lower deep biochemical remission at week 30. So it's, again, same behavior in kids that we saw in adults. So higher weight and lower serum albumin were associated with increased clearance in these patients. So this was a comparison head-to-head of the adult PK estimate with pediatrics. I'm not going to go through every line. Just bear in mind that the central and peripheral volume, we usually add them up to get an idea, and it should be about 0.1 liter per kilo, which is about what they were. And the other parameters are all pretty much the same. And when we looked, for example, at mucosal healing, you can see, for example, at week 30, we had a highly statistically significant impact of patient exposure here. And when we looked at the later study, this is week 14, this is week 30, we saw actually same, it's not quite reaching statistical significance, but it was a relatively small study. And so we had also some effect of previous biologic use. So we ran some simulations to try to come up with doses that would get pediatric patients at different weights to have pretty much the same exposure that you have in children. And you want to bear in mind that these patients who are particularly low weight you're going to have higher peak concentrations, but the goal was to try to keep the trough concentrations fairly consistent. So here we have a 10 kilogram patient, a 20, a 30, and a 40. And you can see that the doses here are actually maintaining very similar exposures. So it's actually not a very difficult thing to do to come up with a dosing regimen that will at least mimic the labeled dose in children. So one of the things that we've noticed, of course, that using a dashboard does take time to learn. So we decided to try to take some smaller steps. We have a model-informed precision dosing system requires a lot of training and resources. And while most physicians have some fundamental training in PK and PD, most of these dashboard systems use specialized Bayesian statistical approaches, and physicians aren't really familiar with that kind of thing. However, they are used to dealing with apps. For example, apps for dosing warfarin are quite common. So we decided to try to make the application a little bit simpler. So we get a slight hit to precision, but a major improvement in speed and ease of use. So here's, for example, MIPD app where all you have to do is pick the drug, the weight, the dosing interval, the observed concentration, and the concentration you want. You hit the button and you get a bunch of different doses and dosing intervals that should keep that patient at or above the target that you've just selected. So there is a difference between indicators of disease activity and progression. For example, in IBD, CRP, and other indicators of disease activity don't really align well with progression, but they often herald impending progression of the disease. The problem is there really isn't a single factor for disease progression that is available for some of these diseases. MAb clearance may be more sensitive, for example, than CRP in indicating response or an impending flare or anti-drug antibodies. The PK of monoclonals is dependent on pharmacodynamics. So as you saw previously, if the disease severity improves, then the clearance will slow down. And if the disease severity is getting worse, clearance will increase. So if the objective of therapy is to halt or at least slow progression, then markers such as individual clearance can be very useful to see how successful the treatment that's being prescribed to these patients is working in them. So I'd like to say thank you. That's picture me in my race car. And in particular, I'd like to thank Dr. Anna Strick, Dr. Walter Reinick, Dr. Stephen Hanauer, Marla Dubinsky, all for their input and patience with me as I tried to learn all about this disease, and in particular this disease in children. And I'll stop there and see if anybody has questions. And I see hands going up.
Thank you, Dr. Mould. This was such a fantastic talk. I know I can probably speak for everyone that we were super appreciative for all the information that was presented today. And I think we have some time for questions. I see that our Q&A box is quite full. So if if you don't mind, we'll just jump right in.
Do my
Wonderful.
best.
Awesome. So from the first attendee, they're thanking you for an informative presentation, and they're wondering if there is room for exogenous albumin therapy in patients with low albumin at the time of treatment with biologics to help reduce variability of response.
That's a really good question. In fact, I had a clinician who tried dosing albumin to their patients with IBD that had low albumin. It's not the albumin level itself. So administering albumin will not help. It's what's happening to the albumin. I call it the canary in the coal mine, right? Canaries used to go down into the coal mine, and if the poisonous gases were bad, then the canary died. Bringing down more canaries doesn't help. It's basically, you want to just, if you're losing albumin through protein losing enteropathy or some other form, whatever happens to albumin is going to happen to an antibody. Good
Awesome.
question, though.
Thank you so much. Um, the next question is, I think they're referring to some of the images that she had presented, but they were talking about which tool or system they can use to create the dashboard.
Yeah, so dashboards take a long time to create. We basically have our system is built using multiple languages, including Python and R and a whole bunch of other GUI type languages. in order to make it fairly useful. And of course, they require a tremendous amount of validation work. But basically, if you are interested in looking at, for example, our software, just send me an email and we can set you up with a test example and you can try it out.
Wonderful. Thank you. So if I hope our attendee is still there. So Dr. Mould is offering some really great advice and some services. So please definitely reach out. So thank you, Dr. Mould. Um, I have another question. So is it common for, oh, excuse me, it is common for patients receiving monoclonal antibodies or thymoglobulin, globulin, excuse me, to be treated, pre-treated with prednisone to reduce cytokine storm. Would that provide enough protection to improve responsiveness while mitigating interference from underlying inflammatory states, for example, in patients with diabetes?
It's a really good question, and I haven't heard of anybody that tried it. It's the only thing I could suggest is that if you do decide to try it, you obviously want to set up a clinical trial, but that might actually be a useful thing to do.
Wonderful. Thank you so much. Another question, pretty lengthy, so bear with me. So you alluded to this issue. Limited therapeutic options are challenging for patients with chronic conditions requiring repeated dosing over time. This is even more concerning when considering pediatric individuals. Limiting the available therapeutic armamentarium in the long term. Is there a relationship between developing ADA to one of the agents and risk and time to develop ADA to a subsequent biologic treatment?
Yeah, it's kind of like that second line where I was showing the probability that the patient will drop out. Basically, whatever it was that caused the patient to develop anti-drug antibodies is still going to be there when you go to the next line. So if it was something like low albumin, you have to bear in mind that this patient is going to be at a higher risk than you would for a baseline patient that you have no experience with. And so you probably want to consider more frequent dosing in the event that this patient has very fast clearance. So you have to consider that whatever was there is still there when you start another drug.
Wonderful. Thank you so much. And then looks like our final question in the chat. Um, uh, they're really intrigued by the increased risk of developing ADA in obese individuals. Is this seen in kids and adults? And can you perhaps comment on the potential mechanisms for obesity in inducing ADA formation? Is it higher inflammation in general? And if there's age specifics?
So most of the data I've worked with for children has been IBD, and those children are generally not obese. I know that if you go into, for example, psoriasis and RA, just because those patients tend to be a little bit less active, if you know what I mean, they do have a higher tendency to have to obesity issues. And it appears to be largely due to the higher circulating inflammatory cytokines, which is why they tend to develop anti-drug antibodies. And as I mentioned, there have been studies done on bioavailability of some of these proteins given when it's given subcutaneously to obese patients. That means that less of the dose is absorbed. So they need more drug and they're absorbing less drug. So right off the bat, they're kind of not being treated appropriately. But IBD patients tend to be underweight, actually, not so much overweight. It's not until they get into remission that they get some weight back on their skeletons.
Oh, wow, that's interesting. Great. Dr. Mo, we are right at time. So perfect timing and everything. Awesome. So I want to thank you again. You're always such a dynamic speaker. And I know that people had way more questions. We just did not have the time for it. But I really thank you for being here today and always supporting the lecture series.
It's great. I'm glad people enjoy it, and I'm hoping that people will continue to attend these lectures. Are great lectures, and definitely keep the series going.
Thank you so much. Since we are at time, I just remind our audience that the next public lecture is going to be February 25th. It's titled Exploring New Therapeutic Options for PCOS, and it'll be presented by Dr. Melanie Cree of the University of Colorado. So I just want to say thank you again to our amazing speaker, and thank you to our audience for your participation today. I hope you all have a great rest of your day.
Oh, thank you very much.